Developmental disorders of the oral and the maxillofacial region. Even before we could speak about it, the development of the oral and the maxillofacial region, it's a beautiful process, but yet it's a very complex process. It starts around, say, the 4th week of the intrauterine life and it proceeds until the 8th week of the intrauterine life. It includes a series of highly coordinated events. The development of face as such includes the nose, eyes, lips, maxilla, mandible, all of which occur simultaneously in a very orchestrated fashion. So, one more thing which we need to remember is all these phenomena take place at a very early stage during embryogenesis, and for the same reason, if any disturbance is going to happen during the development of these structures, it's going to be highly devastating and disfiguring. So this is the topic we are going to discuss now, developmental disorders of the oral and the maxillofacial region. We'll have a discussion in the form of few objective type questions so that we can comprehend the subject better. All are true regarding the development of palate except, okay? So remember, all are true except. Critical period is end of 6th week and beginning of 9th week. Process begins at 6th week but goes till the 12th week. The secondary palate is posterior to incisive foramen. Okay, all these to an extent are fine. But look at the final sentence here. The primary palate is the anterior part, till here it's fine, of the palatine shelves of the maxilla. So the error lies in this phrase. We know that the palatal shelves of the maxilla are completely entirely different anatomical structure, right? So primary palate is different and palatal shelves of the maxilla we know are involved in the development of the secondary palate, not the primary palate. But otherwise, the primary palate forms the anterior part of the palatal region. We know that palate has a primary palate and a secondary palate. Primary palate in the anterior part and secondary palate situated posteriorly. So, this is the false statement for the question given. For us to understand better as how the cleft lip and the cleft palate occurs, we need to know few points regarding the development of the lip and the palate. See, around the 4th week of the intrauterine life, nasal placodes develop on the inferior aspect of the frontonasal process. Okay, I'll mark it as NP. On either side of which a ectomesenchymal proliferation occurs, resulting in the formation of the median nasal process and the lateral nasal process. So the fusion of the two median nasal processes, right, results in the formation of the upper lip, its medial portion, and the lateral portion of the upper lip is formed by the maxillary process. Then what is the lateral nasal process involved in? The lateral nasal process is involved in the formation of the ala of the nose. Okay, so now we know how the upper lip is formed. The upper lip's medial portion is formed by the two medial nasal processes, and the maxillary process only, it's involved in the formation of, say, the lateral portion of the upper lip, whereas the lateral nasal process is involved in the formation of the ala of the nose. So now we know that if cleft lip occurs. The defect will be in the fusion of the two medial nasal processes, or if there is going to be a defect in the maxillary anterior alveolar ridge between the two incisors, where we called as the midline cleft of the upper lip, and also the midline maxillary anterior alveolar cleft. In those regions, the problem is with the defective fusion of the two medial nasal processes. I will be reiterating the same concept with illustration, but before then, we need to let our imagination go on. Okay? So, this is about the development of the lips. Now, coming to the development of the palate. Alright? We have the primary palate and the secondary palate. Remember, the primary palate develops from the fusion of the two medial nasal processes, just like the medial portion of the upper lip. Whereas the secondary palate is formed by the palatine shells of the maxilla. All of this occurs between the 4th to the 6th week of the intrauterine life. Okay. So, especially the secondary palate, the complete development proceeds from the 6th week to the 9th week of the intrauterine life. So, I was telling about the palatine shells. Initially, when the medial processes of the maxilla, they develop and they are in a vertical position. So, you can imagine that when the two palatine shells are in a vertical position, there is a gap in between. Now, this space is occupied by the higher position of the tongue. With the growth of the mandible, what happens? The tongue descends down, letting the two palatine shells to rotate to a horizontal position and starting their fusion from the anterior to the posterior direction, completing the formation of the secondary palate. Alright? So, the primary palate is done once the two medial nasal processes fuse with each other at the intermaxillary segment and complete that portion of the palate anterior present in the maxilla, that segment which involves the canine to the canine region. Okay? The first 6 teeth, the anterior teeth. And the secondary palate development occurs and gets completed only after the mandible grows, the tongue descends down and the palatine shells rotate from the vertical to the horizontal position, completing their fusion at the mid-palatine raphe region from the anterior to the posterior direction. So now you know cleft palate occurs when there is a defect in the fusion of the palatine shells or defect in the fusion of even the medial nasal processes where there will be a defect of the primary palate. So this is the picture you need to know. So I was telling about the nasal placodes, right? So this portion is a nasal placode which will later become the nasal, it will form a depression, right? The depression will become the future nostrils. On its medial part and the lateral part, you have the medial nasal process and the lateral nasal process. So the two medial nasal processes join to form the upper lip and also the primary palate. Whereas the maxillary process is involved in the formation of palatine shells which fuse together from the anterior to the posterior part to form the secondary palate. Remember, medial nasal processes are also involved in the formation of the primary palate. Okay? So, now we will be able to understand cleft lip and cleft palate better with this basic knowledge of the formation of the lip and the palate. According to Bue's classification of cleft lip and cleft palate, isolated cleft palate falls under its Group 2, for which we need to know what is Bu's classification is. There are many classifications for cleft lip and cleft palate, but at least Bu's classification is one conventional and basic classification which all of you are expected to know. Alright. So group 1 is defects involving the soft palate alone. Okay. And group 2 defects involving the soft palate and hard palate. The group 3 is the cleft involving the soft and hard palate and the alveolus unilaterally. And group 4, soft palate, hard palate, alveolus bilaterally. Alright. So this is a very simple classification for cleft lip and cleft palate. You might have questions on this. So how does the facial profile of the patient looks like? You see this? This is a normal palate. The alveolus is complete, the soft palate, hard palate along with the uvula are complete. But here in unilateral cleft, it starts from the soft palate, hard palate involving the alveolus and the nostrils. It's opening up into the nostrils, right? It's a fistula, a through cut fistula develops, and opening is present between the oral cavity and the nasal cavity. Here this is the bilateral cleft lip and cleft palate. You see that the alveolus has breaks at two portions bilateral? Yes. Now, just not this. You should know about the other types of cleft lip and cleft palate. Mainly, the clefts involving the oral maxillofacial region. The other clefts are the lateral facial cleft, oblique facial cleft, the midline cleft of the upper lip, and the median maxillary anterior alveolar cleft. Okay. Two important things at least you should remember as far as various clefts are concerned. How is the cleft formed? Okay. Defective fusion of which processes result in the cleft, and how is the clinical presentation? Where exactly the cleft occurs? Which are the structures affected? As far as lateral facial cleft is concerned, there is a defect in the fusion of the maxillary process and the mandibular process. So, what can you expect? If the maxillary and mandibular process itself are defective in fusion, there will be a cleft extending from the commissure of the mouth to the ears. Okay, the patient will have macrostomia. So, this cleft will extend from the commissure to the ears. In oblique facial cleft, this cleft is because of the defective fusion of the maxillary process and the lateral nasal process. So, you will have a cleft extending from the upper lip to the eyes. Most often, this cleft will be always associated with cleft palate. Midline cleft of the upper lip, failure in the fusion of the two median nasal processes from each side, but involving the upper lip. Say the lip is this way, the patient will have a cleft in the mid portion of the upper lip. Median maxillary anterior alveolar cleft is little more an extension of the midline cleft of the upper lip. It's again the defective fusion of the two median nasal processes, but here there is a bony defect. The alveolar process is notched in between the two central incisors. So what do you think this cleft is? It's a cleft extending from the corner of the mouth, the commissure of the mouth, and it goes up to the ears. So this is lateral facial cleft. Next picture, you see the cleft extending from the upper lips to the eyes. This is oblique facial cleft. Here, the cleft involves the upper lip in the midline. So it's a midline cleft of the upper lip. Here, you find the bony defect clearly between the upper anteriors, especially the incisors. Midline of the maxilla in the anterior part. That's why it's named as median maxillary anterior alveolar cleft. Okay. So now that you know the various types of clefts, the conventional classification of cleft lip and cleft palate. Broadly, you have three categories: cleft lip, cleft palate, cleft lip with cleft palate. Usually, cleft palate, cleft lip with cleft palate are considered as one entity. Cleft lip is the prevalence is relatively less compared to the other two categories. Okay. Now, let's see a case study. What is this about? A 6-day neonate presented with complaints of feeding and respiratory difficulty. On clinical examination, the neonate had micrognathia, U-shaped cleft palate and glossoptosis. Okay, falling back of the tongue. What is the diagnosis? So all these three features are characteristic of, yes, PeriRobin syndrome. When we arrive at an answer, we should also give justification as why we are excluding the others, right? So, in next slide, I have put the pictures of the rest that will give you a better picture. So, the first option was Marfan syndrome. So, what is abnormal in this picture? Patient is having long hands, long fingers, digits, arms. That's because Marfan syndrome is an inherited condition where there is a defect in the connective tissue. Just not the arms, the legs, the limbs. It mainly involves the heart, eyes, blood vessels. Yes, the connective tissue all over the body is affected. That is Marfan syndrome. Picture B, the option given was Cruzen syndrome. It's a synostosis condition where there is a premature fusion of the cranial sutures. Here, this is ParryRomberg syndrome, progressive hemifacial atrophy, where atrophy occurs in one side of the face progressively. You find hyperpigmented areas of the skin and the hypoplasia of the bones and also the soft tissues. The subcutaneous tissue is also affected. So, this is ParryRomberg syndrome. So, we've seen Marfan syndrome. Here this is Cruzen's and this is Marfan's. And this was a question asked to us, which is PeriRobin anomaly. So what is that subtle difference in the terminologies of all these three conditions? We call all these three as syndromes, but here we called it as PeriRobin anomaly. Why it is an anomaly? Anomaly also has a combination of symptoms, but each symptom is interconnected with each other. The primary structural changes one primary structure change will give rise to the other primary structural change. Okay, to elaborate on it, to emphasize on it a little more. These children will have micrognathia. Now we know during the development, the mandible has to grow for the tongue to descend down and for the palatine shells to close and complete the formation of the secondary palate. Now what if the patient has micrognathia? It will not let the tongue to descend down. So the tongue will be in a raised position, not letting the palatine shells to close, which is left behind separated, leaving a cleft palate. So the characteristic feature of PeriRobin anomaly is glossoptosis, poor control of the tongue musculature. The tongue tries to fall back and the patient will have airway obstruction and respiratory difficulty. So that was the question given to you, the clinical symptom which was given to you in a multiple choice question seen in the previous slides, right? So you see how the palatine shells are vertical, it has to fuse, but this does not happen. So it remains open and the cleft persists. The palatine shells do not close. So this is what we need to remember. These two words sound very similar, right? PeriRobin anomaly and this is ParryRomberg syndrome. We already saw ParryRomberg syndrome is progressive hemifacial atrophy. Just not the bones but the cutaneous atrophy also occurs and even the subcutaneous tissues, the muscles, the bones, the soft tissues, all of which get atrophied on one side of the face progressively. So that is ParryRomberg syndrome and this is different from PeriRobin anomaly. Okay. Now we need to discuss about few similar conditions. Here, this patient will have hyperplasia on one side of the body as such. So, it's called as hemi-hyperplasia. The jaws, one leg, one hand, one side of the face, say the first and the fourth quadrant. Okay, the entire one side of the body undergoes hyperplastic process, that is hemi-hyperplasia. Everything is normal for the patient, but there is hyperplasia of just one quadrant alone, in which case it's called as segmental odontomaxillary dysplasia. It's a relatively new entity compared to the others. And the third one is, what do you find? This is hemifacial hyperplasia in the face. Just not the bones alone again, just not the alveolus alone again, as we saw in segmental odontomaxillary dysplasia. You find the tongue is enlarged on one side, the alveolus is enlarged, the teeth will also be enlarged on that side. So that you call it as hemifacial hyperplasia. So these are all related conditions. You need to orient each condition with an illustration or a picture in mind for you to remember better. Alright? Peutz-Jeghers syndrome is again an inherited condition, and it's characterized by, yes, multiple intestinal polyps along with perioral pigmentation. There will be a numerous gastrointestinal polyps all over the gastrointestinal tract, more commonly in the intestines. A patient notices a well demarcated area of depopulation on his tongue, which has been there for a long time. As he could remember, the most probable diagnosis is, yes, it's median rhomboid glossitis, because one of the etiological factor attributed to the development of median rhomboid glossitis is some disturbance in the development of the tongue at the region of the cubicular impart. But what are the other options given to us? Geographic tongue. This doesn't match with the statement given. What is geographic tongue? It's otherwise called as benign migratory glossitis or erythema migrans, where there is a depopulation of the filiform papillae showing erythematous area but surrounded by white serpentine borders, clear-cut white serpentine borders, and they do not stay in a place. They keep moving around the tongue in different locations. As they heal in one place, they come around in the other place. Black hairy tongue is accumulation of keratin on the filiform papillae, and overadded debris, pigments, the external agents gives the color to it. It could be because of poor oral hygiene, radiation therapy, okay. So, this is black hairy tongue. And what you see there finally is mollusc glossitis. That is because of vitamin B12 deficiency. It's a vitamin deficiency causing the atrophy or the depopulation of entire tongue, leaving a barred surface. Okay. Identify this condition. There are small mucosal invaginations on the corner of the lip. You find that? Yes. So, as the name goes, according to the anatomy, they are nothing but the commissural lipids. Okay. And when you try squeezing out this portion or try palpating, you will find few secretions coming out. That is because of the minor salivary glands present at the depth of these small invaginations. Now, it's just not one lipid. We have another condition called as congenital lipid. Okay. So, here the location is the corners of the mouth. Here, paramedian lipids are also called as congenital lipids and congenital fistula of the lower lip. There are three names given to it. It's more of a congenital condition, and here you find it in the lower lips on either side of the midline. Here it's mostly not associated with any syndromes. But for few preauricular sinuses might be associated in few cases. But here it is associated with what is known as the van der Wood syndrome. Okay, van der Wood syndrome is association of paramedian lipids with cleft palate. The next thing is popliteal pterygium syndrome. There is congenital band formation between the upper and the lower jaws along with cleft lip and or palate along with some genital abnormalities. Next is the kabuki syndrome. Okay. Here there is an eversion of the lower eyelids. It's named so because the patient looks similar to the artist of the Japanese theatres. That is the reason why it's given that name. Along with paramedian lipids, the cleft lip and or cleft palate, mental retardation, hypoplasia of the maxilla or the mandible could occur, joint laxity could be present for these patients. So you have three syndromes to remember as far as your congenital lipids or paramedian lipids are concerned, which is not the case with the commissural lipids. What is this then? There is a redundant fold of tissue on the upper lip. This is nothing but double lip. Double lip could be formed because of a congenital cause, or it could be because of an acquired cause. Okay, congenitally if it is present, it might get associated with few other conditions like blepharochalasis, and non-toxic thyroid enlargement, in which case it is called as Asher's syndrome. Okay, it's one form of congenital presentation. And what could be the reason for an acquired variant of it? It could be because of deleterious habits of the patient. A lip sucking habit can also induce this double lip formation. Ideally speaking, it is unnoticed when the patient remains calm, but when the patient tries to smile, it becomes more evident, right? So, is this word new for you? Blepharochalasis? So, blepharochalasis is nothing but there is an edema of the upper eyelids. The edema is so much so, the upper eyelid will start to sag and the patient's vision might be obscure. Along with non-toxic thyroid enlargement and double lip, you call it as Asher syndrome. So, this is a case of Asher syndrome. You find the blepharochalasis here, the edema of the upper eyelids, you have the double lip, and probably not in all cases the patient will have non-toxic thyroid enlargement. But if it's present or even otherwise, if these are the two main features along with non-toxic thyroid enlargement, it constitutes what is known as Asher syndrome. So what do you observe here? Clinically, when the patient comes and you find these crenations on the corner of the sides, the lateral borders of the tongue, the first thing which should strike you is macroglossia. Okay, abnormally large tongue. And there is another word called as relative macroglossia, in which case the tongue is of normal size, but if the jaws are smaller. When the patient has micrognathia, the tongue will appear as if it is large. That is relative macroglossia. Now coming back to true macroglossia. So I am very sure you will be able to identify all these pictures as macroglossia. But remember, macroglossia is not a disease entirely by itself. It is a condition which is found in many other diseases. For example, not always the tongue is uniformly large, a smooth diffuse enlargement is present. Okay? Here it is nodular, there it is small nodules are present in the anterior part. There are various presentations. Let's see how macroglossia occurs in each of the disease conditions. When it is smooth diffuse, okay, enlargement of the tongue, probably the patient could be suspected of having hypothyroidism. In hypothyroid patients, macroglossia, if it occurs, it's smooth and diffuse. And there is a syndrome which you need to remember, that is Beckwith-Wiedemann syndrome. I write it down so that you get acquainted with the spelling. Okay, Beckwith-Wiedemann syndrome. Even in this syndrome, it is diffuse and smooth. What is this syndrome about? You have four features: omphalocele, visceromegaly, gigantism, and neonatal hypoglycemia, of which I understand that omphalocele is a little foreign term. It's nothing but there is a defect in the abdominal wall, and through this defect the intestines try to protrude out. So that's one component of Beckwith-Wiedemann syndrome. Now, when it's going to be multinodular like this, you can think of some accumulation of proteins inside as in amyloidosis, or macroglossia could present as a multinodular tongue in neurofibromatosis, multiple endocrine neoplasia, or the tongue could be enlarged as we already saw in hemifacial hyperplasia. It could be fissured, papillary, with enlargement as seen in Down syndrome. The enlargement of the tongue might show pebbly vesicle-like surface as we see in lymphangioma. So these are the varied presentations of macroglossia. Okay, just to quickly run through the tongue conditions which we commonly see. Multiple areas of desquamation of filiform papillae. You call it as benign migratory glossitis, geographic tongue, which keeps changing places, right? Otherwise even called as erythema migrans. Atrophy of filiform papilla with normal or engorged fungiform papillae, B12 deficiency, or even in B2, riboflavin deficiency. Hypertrophy of filiform papilla in black hairy tongue or lingua villosa. Absence of filiform papilla is seen in median rhomboid glossitis. Hope we saw the illustrations, the pictures of all these conditions. Swollen, hypertrophied fungiform papilla in strawberry tongue, scarlet fever. Okay, absence of fungiform and circumvallate papillae is seen in familial dysautonomia. So these are few of the conditions where the tongue has pathological presentation. Now what is this? A 35-year-old patient presented with swelling of the upper lips. Yes, we do find that. Facial paralysis. You see one side of the face doesn't show any movement, and fissured tongue. But there is no systemic diseases and there is no regular drug use. So this is a case of Melpas and Rosenthal syndrome. What are the components present in Melpas and Rosenthal syndrome? Cheilitis granulomatosa of Nature, facial paralysis, and fissured tongue, otherwise called as scrotal tongue. Cheilitis granulomatosa is a non-specific, non-tender inflammatory condition. It's a diagnosis of exclusion. You have to exclude all other conditions which could cause enlargement of the face and the orofacial region structures, and then still if the patient has swelling of the orofacial tissues, especially the lips, you call it as a component of orofacial granulomatosis is cheilitis granulomatosa of Nature involving the lip alone. So we have the other options also, right? In the Fraze syndrome, you find that the parasympathetic nerve fibers of the auricular temporal nerve getting re-innervated along the sympathetic fibers after a parotidectomy, a parotid surgery, or any injury. So when the patient next time after this regeneration has occurred, and the patient tries to eat each time, and salivation has to occur, the sympathetic fibers also will get activated, resulting in flushing in and around the periauricular preauricular region. So that's a case of Treacher-Collins syndrome, mandibulofacial dysostosis, a defect in the development of the first and the second branchial arches. We'll be discussing about it in the subsequent slides. Moving on to the next question. Identify this disease condition. So what is that arrow pointing out? It is the coronoid process. That is a hyperplasia of the coronoid process. So this is a case of coronoid hyperplasia. Okay, it could be unilateral, bilateral. In most cases, it's unilateral. If it's going to be unilateral, it's going to impinge on the zygoma, right? The posterior aspect of the zygoma. The patient might have difficulty in mouth opening, and the mandible will try to deviate towards the affected side. Bilateral, yes, it could occur. It could be a coronoid hyperplasia, a true coronoid hyperplasia by itself, or it could be because of a tumor condition involving the coronoid process, like osteomas, osteochondromas. Yes. Now, what are these two conditions? Very similar conditions. Here also you find facial asymmetry, but look into the picture. Here it is the condyle which is getting affected. Here there is an elongation of the condyle. So the patient is having condylar hyperplasia. In this case, there is a disturbance in the developmental center of the condyle. This is condylar hypoplasia. You find the mandible midline shift towards the affected side. But in both these conditions, you will find facialis asymmetry. The occlusal slant has got altered. There is an occlusal disharmony. Cross-bite, open bite, yes, will be present. But this condition could be either condylar hypoplasia, could be either congenital or acquired. Congenital, it could be associated with few other syndromes like mandibulofacial dysostosis, oculoauriculovertebral syndrome, what you call as the Gardner syndrome, hemifacial microsomia, and it could be acquired also. Say during the infancy developmental stage, the child is subjected to some form of radiotherapy, infection, or any form of rheumatic or degenerative arthritis can also disturb the development of the condyle, resulting in condylar hypoplasia. Okay. So what do you find one common thing in all these four pictures? It's nothing but they are localized bony projections found on the alveolus in different parts. So in the first picture, you find bilateral row of hard bony nodules on the facial aspect of the maxillary alveolus and also to an extent in the mandibular alveolus. It's nothing but exostosis. Here, the same localized bony projections which are benign growths not causing any pain unless the the ovine mucosa is traumatized. Okay, it doesn't cause any pain. On the lingual side of the mandible near the premolar region. So, it's Taurus mandibularis. And Taurus palatinus is the same bony projections which occur in the vault of the palate, in the midline of the palate. But based upon their shapes, they could be flat, spindle shaped, lobulated, nodular. Okay. So this what you see is more of a, you can call it as a nodular, not exactly nodular, it could be a flat torus because it has a sessile, it has a one single base. This is spindle shape because it's elongated along the mid-palatine traffic. Suppose the same presentation, there are many nodules like this, then you call it as nodular and they will fuse together, try to place together, forming grooves in between. Okay, and lobular is, it will be more lobulated mass, again with a individual base, a common base. Based upon the shapes, you have various type of Taurus palatinus. Only that there might be a problem in denture construction, it has to be surgically removed accordingly. Now moving on to the next question. This is located at the junction of the median nasal process, lateral nasal process and maxillary process is called as, yes, it is the Mesoalveolar cyst. The question is posed such that it's located. Yes, why it is located there? That's because you know that these three components, medial nasal process, lateral nasal process, maxillary process are three separate embryonic structures which are fusing. So in the process of fusing, there might be some epithelial remnants which has got impregnated or got stuck up within those lines of fusion, resulting in the formation of a cyst which might initiate a cyst formation. Okay, so that is the histogenesis of this Mesoalveolar cyst. Remember, Mesoalveolar cyst is a soft tissue cyst. It does not involve the underlying bone unlike the other fissural cysts. Globular maxillary cyst is a soft tissue cyst often present between the maxillary lateral incisor cuspid teeth, often present between the incisor cuspid teeth but is a bone cyst. Yes, a cyst present between the midline of the palate. Is it that? Is it present between the midline of the palate? No. A cyst present in the incisive canal? No. It's often present between the incisor and the cuspid teeth as very much evident on the radiograph, inverted pear shape. Okay. Which is a soft tissue cyst. We saw that Mesoalveolar cyst is a soft tissue cyst. This is a bone cyst and that's why we went for the choice. Midline of the palate, you have the median palatal cyst or midline palatal cyst, okay, which will be posterior to the palatine papilla, posterior to the incisive canal. cyst present in the incisive canal? No. That is your nasopalatine cyst. We'll be seeing about it. So, first picture is nasolabial cyst, soft tissue cyst. The soft fluctuant swelling in the anterior part of the palate. You find that a well circumscribed radiolucent lesion present in the anterior segment of the palate. That is your nasopalatine cyst. This is the mid-palatine cyst. To say it is a mid-palatine cyst and to differentiate it from the nasopalatine cyst, mid-palatine cyst will be present posterior to the incisive canal. Okay, posterior to the palatine papillae. It will have no connection with the nasolacrimal duct or the incisive canal. So what is the last one? Nothing but the globulomaxillary cyst, as we saw in the previous slide. So usually present between the cuspid and the incisor tooth. You see this inverted pear shape, periclassical or globulomaxillary cyst. What is your diagnosis with this picture and histology diagram? Yes, it is stratified squamous epithelium, but do you find that lymphoid tissue just subjacent to the epithelium? And clinically you find a lateral neck swelling along the anterior border of the sternocleidomastoid muscle. Yes, this is a case of branchial clefts because of the entrapment of epithelial remnants in the branchial clefts during the formation of the branchial arches. Identify this condition. It's a midline swelling. It's painless, fluctuant, movable swelling. It will move vertically during swallowing, okay? Because of its attachment to the hyoid bone. I am adding on to the clue. This is an example of the thyroglossal duct cyst. A little more on the embryogenesis of thyroid gland, okay? Thyroid gland development starts from the floor of the mouth. You know, from the foramen cecum, the thyroid enlarge around the 3rd week. It will start descending down through the thyroglossal duct till it reaches its final position below the hyoid bone, okay, in close proximity to the trachea. But anywhere during this descent, it's going to stagnate. The descent is going to stop for some developmental disturbance. There it gets lodged as an ectopic thyroid. But how does this thyroglossal cyst forms? Thyroglossal cyst forms. Ideally speaking, this thyroglossal duct after development should degenerate. But when it does not completely degenerate, when the remnants stay behind and because of some trigger, these remnants initiate cyst formation, they end up in thyroglossal duct cyst. So now you know the pathogenesis of ectopic thyroid tissue and a thyroglossal duct cyst. See, these two words, bones, nodules, Epstein pearls, are quite interchangeably used. Some textbooks say bones nodules are small papular keratin-filled cysts present near the junction of the hard and soft palate. Epstein pearls either alveolar ridge or in the midline raphe region. But they are commonly called as the palatal cyst of the newborn. A 22-year-old female patient presented with pain in the right side of the face and the neck without any visible deformity. There is no facial asymmetry as such. Otherwise any swelling, no. There is no obvious clinical presentation. But when an OPG and a CT was taken, you see that there is an asymmetry in one of the structure. This is nothing but the styloid process. The styloid process of one side is longer than the other side. So this is a case of Eagle syndrome or stylohyoid ligament syndrome. Now remember, there are two descriptions and accordingly there are two entities. One is the classic Eagle syndrome, which follows tonsillectomy, where there is a scar tissue formation along this stylohyoid ligament which will eventually mineralize, resulting in cervicopharyngeal pain because it involves the 5th, 7th, 9th and the 10th cranial nerves. The patient will have difficulty in swallowing. Authors say that stylohyoid ligament syndrome or the carotid artery syndrome stands a little different away from the Eagle syndrome in a way that the mineralization of this ligament, okay, or the styloid process, it will impinge or puts some more pressure on the adjacent carotid arteries. When it gives pressure to the adjacent carotid arteries, then the patient will have pain simply by turning the head. Okay, turning the head, neck, and you will find that sort of pain will radiate to other parts of the head and the neck. So that is carotid artery syndrome. And the third small variant of it is traumatic eagle syndrome, where this mineralized stylohyoid ligament. Stylohyoid ligament is nothing but the ligament connecting the styloid process and the inferior conio of the hyoid bone. So if that is going to fracture, the patient will end up in traumatic eagle syndrome. This is what you need to know. But you should identify them in the OPG and the CT scan. Goldenberg syndrome is nothing but oculoauricular vertebral syndrome. 9-year-old patient presented with hyperplasia, facial bones, maxilla mandible, cheekbone, antemongoloid slant, pathobred features are slanting, coloboma of the lower lid, bilateral anomalies of the auricle, high arch palate, micrognathia, mouth breathing, malocclusion, microstomia, small mouth, incompetent lips, very characteristic of Treacher-Collins syndrome, or otherwise called as mandibulofacial dysostosis. Okay, otherwise called as Francis-Shetty-Swaley-Kleene syndrome. Okay, if possible, try remembering this word. These two is more than enough in case. Just have a look at this word. These are the other synonyms for it. Why I am emphasizing it is this is one among the other 4 or 5 syndromes which are must to know, although you have a list of syndromes to remember. So what happens here is the structures developing from the first 2 branchial arches are disturbed. There is a developmental disturbance. Mainly the lower face, the neck and the upper thorax. The structures whichever develops from here are getting affected. First is the zygomatic hypoplasia. The mid face is sunken inside. Maxillary hypoplasia is present. And the patient will develop a coloboma. What is that coloboma? It's a notch in the outer part of the lower eyelid. Patient might have a lateral cleft extending from the commissure to the ears. Ear defects. Your ossicles might be affected. The condylar, coronoid hypoplasia, hypoplasia of the nasopharynx, hypopharynx, okay, salivary gland hypoplasia can occur. The mandible is also retrognathic in these patients. Obviously, when so many structures are affected, how can you expect the dentition to be? There will be excessive crowding, V-shaped palate and the alveolar ridges. So, these are characteristic of mandibulofacial dysostosis. Static bone cyst is a cyst developing from because of infection or just a tissue of odontogenic apparatus, tissue of oral mucosa. No, none of the above. It is not even the tissue of oral mucosa. Remember that it's just a focal concavity found in the body of the mandible on the lingual aspect where it harbors some amount of salivary gland tissue. Posteriorly, if it is present, it's just the submandibular salivary gland which is lodged here. But more specifically, you can arrive at this diagnosis because this focal concavity in most cases will be below the inferior alveolar canal. Above the canal, you can think of some cysts of odontogenic origin, say aneurysmal bones, traumatic bones. You can think in those lines, but below the inferior alveolar canal, first thing you should think of, especially if it's asymptomatic, salivary gland depression. Okay, so accordingly it's very static, it's very quiescent, so you call it as static bone cyst. Also Staphnese bone cyst, there are a lot of synonyms for it according to the anatomic location. The same defect can even occur in the anterior part of the mandible on the lingual aspect where it is occupied by the sublingual salivary gland. Alright, that's none of the above, it's a salivary gland tissue and track that. Now, this is one concept I wish you could understand because there are 2 syndromes which is a part of the developmental disturbances of oral maxillofacial region, which is quite often asked in your exams. So this basic is important to understand those syndromes. What is craniosynostosis? Remember that the cranial sutures will take its time to fuse, but premature fusion of cranial sutures, you call it as craniosynostosis. So what if it gets prematurely fused? If it's going to get prematurely fused, the development of the brain is going to get affected and it's going to take deviation in its direction. Okay, the skull development, even the shape, right from the shape, it's going to change. So you know the common sutures of the metopic suture, coronal, sagittal, lambdoid. Okay, this is in normocephaly, in normal skull. When you say the skull has taken trigonocephaly, triangle shape, you find that the metopic suture has prematurely fused. You don't find a metopic suture here. Here the sagittal suture is prematurely fused. So it results in a boat-shaped head. Scaphocephaly is nothing but a boat-shaped head. And bicoronal sutures are fused, prematurely fused. It results in brachycephaly. Brachycephaly, it's a very short head. So at least these things you should remember. Accordingly, the lambdoid suture could get, you see the shape of the skull is changing according to the suture which is involved in craniosynostosis. Now we need to understand this to answer this type of questions. A 6-year-old child with frontal bossing, asymmetrical skull growth, exophthalmos, hypothyroidism, wide nasal bridge, low set ears, hyperplastic maxilla with relative mandibular prognathism, and the child often cries telling that he or she has a headache. What should this question prompt you of? This is a case of Cruzen syndrome. See, a headache strongly associated with skull growth. Okay, so Cruzen syndrome is one craniosynostosis condition where it's occurring because of mutation of fibroblast growth factor receptor 2 gene, and the patient will have brachycephaly short head, scaphocephaly boat-shaped head, and trigonocephaly triangular-shaped head. The patient will undergo what is known as a clover leaf skull. Okay, the patient will not have. There are many sutures which are getting prematurely fused. The term used is cleat back scadal deformity. Just not above the skull, the orbit is sunken, which it will be very shallow orbit. So obviously the eyeball will come out. Ocular proptosis, hearing deficit, visual disturbance, maxillary hypoplasia, V-shaped palate. All these are features of Cruzen syndrome. You will even find lateral swellings within the palate. So let's see what's the next syndrome closely associated with it. 19-year-old patient presented with acrocephaly, flattened occiput. Flattened occiput, it looks like a tower, right? It's a tower skull. Maxillary hypoplasia, teeth crowding, ectopic teeth, mandibular, pseudoprognatism. Why pseudoprognatism? Pseudoprognatism, the word is given because the mandible is not prognatic. It's because of the maxillary hypoplasia, which causes the mandible to look as if it's prognatic. Flattened nose, okay, low bridge, proptosis, hypothyroidism, cutaneous syndactyly. Most of the features overlap with Cruzen syndrome, but in addition, this patient is having even webbing, or there is a fusion of cutaneous fusion. Even the skin is fused between the digits, especially the second, third and the fourth digits are fused. That is syndactyly. All these are features of nothing but the Apert syndrome. Okay. Now, Apert syndrome, last but not the least, having known so much, it goes without saying, the genes are basically involved in all these developmental disturbances. There is mutation in some gene or the other, right? So, the gene that defines the localization of the tooth germ is, it's PAX9. There are few other genes. At least remember few of the genes and their functions. Bone morphogenetic proteins 247, mainly they are involved in tooth morphogenesis. MSX PAX9 helps in the functioning of the fibroblast growth factor. They are involved in the development of the connective tissue structures. MSX1, MSX2 by the epithelial mesenchyme interaction. There is a lot of epithelial mesenchymal interaction which is going on. We need that for this gene to work properly, for epithelial mesenchymal interactions to go on well. PAX9 is a transcription factor regulating tooth morphogenesis and localization. As what decides the crown, the root, the shape of the crown, the number of the roots, yes, we need PAX9. So these are few genes you can remember and their functions, which might in meager cases could be posed as one of the objective type questions in your exams. So you are not very too far from what you want to achieve. Work hard, dream big, and never give up.